Ladies and gentlemen, on behalf of General Electric Healthcare and on behalf of Professor Barbato and Professor Oldroyd, I would like to welcome you to this session called Simplifying Your FFR Procedure. And first, I'd like to spend a few words about the objectives of the session. In the first place, why and how should functional assessment be performed? We can be rather short about that in one slide. Then Professor Barbato will discuss the importance of full hyperemia. Professor Oldroyd will discuss the presently available hyperemic drugs in FFR assessment, and I will tell a little bit more about the hand-on experience with regadenoson, a new hyperemic drug. Why should functional assessment be performed? Well, that's easy to answer. There is incontrovertible evidence from many randomized controlled trials that FFR-guided PCI is better than angio-guided PCI, that FFR-guided PCI improves symptoms and outcome, both in stable angina and in acute coronary syndromes, and that deferral of PCI based upon FFR is safe and decreases the rate of myocardial infarction at follow-up. How should functional assessment be performed? Either by FFR measurement under conditions of full hyperemia, stress, or without stress, with resting ND-chest. And although initially there were studies like Define Flare and Sweetheart suggesting that resting ND-chest was not inferior to FFR, recently it has become more clear that we have to be a little bit more cautious by interpreting that. What we should realize is that in those studies, the first step for analysis was an angiographic assessment of lesions. In those studies, a lesion was assessed by visual estimation, and if it was more severe than 70%, it was stented anyway, without any physiologic measurement. And in those studies, in the Define Flare, in 42% of all stents placed, no physiology was used at all. And in the Sweetheart, that number was 49%. So in fact, by eliminating those lesions, the false negative IFRs were eliminated from the analysis. And only in the patients with mild or moderate lesions, the comparison was performed. So in that group of low-risk lesions, indeed, resting ND-chest were not inferior to FFR, but at the same time, the advantage of physiology is fading. We know from the FAME study that about 30%, that there is a reduction of 30% in all events when you guide your PCI by physiology, but 2/3 of that advantage is caused by the lesions between 70 and 90%, and only 1/3 by the lesions between 50 and 70%. And consequently, although initial guideline changes were made and also included the resting ND-chest, there was a recent correction of the American guidelines validated and lacked the clinical outcome data, and that fractional flow reserve is still the reference standard because the other ones have not been as well studied as FFR. Having said that, I think we are ready for the first presentation by Professor Barbato from Naples, and he will discuss with us further the importance of full hyperemia. Emmanuel, it is a pleasure to announce you.
Thank you very much, Nico, for the kind introduction. Good afternoon, everyone. Thanks for being all here. So the importance of full hyperemia. These are my disclosures. And these are the points I will try to discuss with you this afternoon during my presentation. So I will try to convince you that when we are measuring pressures, what we mean is to measuring and assessing flow. We'll discuss a bit about the instability of resting conditions. We'll also touch upon the importance of full hyperemia as, at the end of the day, we'll unmask what is relevant to all of us, to the interventional cardiologists. And finally, we'll discuss the prognostic importance of hyperemic assessment. But let's start from scratch. When measuring pressures means assessing flow. Clinically used invasive functional tools rely on pressure measurements. I think we agree on that. Yet the objective is to inform on the impact of the coronary stenosis on flow reduction. And only during hyperemia, a linear relationship exists between coronary perfusion pressures and flow, enabling to estimate flow from pressure. So what you see here on the right side is on the x-axis, if I can get the mouse working, the perfusion pressure, on the y-axis, the coronary blood flow. What does this practically mean? It means that if we have a reduction in the hyperemic coronary perfusion pressure such that the the pressure from 100% is decreased to 70%, this means also that there is a consistent reduction in the hyperemic coronary blood flow from 100% to 70%. So in other words, a hyperemic coronary pressure reduction to 70% or an FFR of 0.7 means a reduction of flow of at least 30%. That is what it means. And we can make these assumptions because we are under hyperemic conditions. Let's talk now about instability of resting conditions. And I borrowed this slide from Nico Pijls. This was a patient that he catheterized in his lab. He was presenting with a long, mild to moderate proximal LAD lesions. You can see this on the right side. As we normally do, we perform the equalization of the pressures as measured by the pressure wire and the hydrostatic pressure at the tip of the guiding catheter. So at this point in time, we had 1. The ratio between the two pressure was 1 at this very moment. Pressure Y was advanced in the distal LAD, and what you see here is a value of 0.91. We still did not induce hyperemia. And the patient in this very moment was asleep, was calm. But just a few seconds later, he was awake, he became awake, and the PDPA ratio decreased down to 0.86, suggesting that there was some sort of hyperemic response going on. A few seconds later, Nico started to explain to the patient what he was going to do by inducing intravenous infusion of adenosine, by inducing hyperemia, and look, just by hearing that hyperemia was coming up, the patient was becoming already hyperemic on his own. The PDPA decreased further to 0.83. Then he played around, Nico, pulled back and pushed forward the pressure wire. And you know, each time you do that, you touch the intimal layer of the vessel. And by doing that, you can induce some further vasodilation. And the PDPA decreased even further. Finally, we got hyperemia here, and the value of FFR, the PDPA under hyperemia, is FFR, as we all know, was 0.69. Then we got back to baseline, stopping the infusion of adenosine, and after 5 minutes, you see that the PDPA could never return to the baseline value of 0.91, the one we measured at the very beginning when the patient was calm and quiet, meaning that there was some sort of residual vasodilatation still ongoing. Of course, we need to make sure that there is no drift, and that is why by pulling back the pressure wire, this was checked, and indeed the measurements were correct. So to summarize, what is resting? To borrow again these words from Nico, nothing is so variable in the cath lab as resting. In the same patients, without introducing any external interferences, if not speaking to the patients, informing to the patients, we obtain different value of resting PDPA. Just to make you aware of what is resting conditions within the cath lab. Next, post-occlusional hyperemia was the original experimental method used to achieve hyperemia in our lab, actually. Duration of post-occlusional hyperemia is longer, even longer than with intracoronary adenosine. You see on the right side the variable duration of hyperemia after having occluded the coronary artery with a balloon. That means that resting conditions might be even more difficult to achieve post-PCI. And I'm not saying this by chance, because nowadays measuring physiology post-PCI is becoming of increasing interest to the interventional cardiology community. I refer, of course, to the defined PCI study that was recently presented that has indeed identified some residual atherosclerotic burden of functional importance after stenting the coronary artery. But look at the IFR trend. Most of those tended to improve, suggesting that indeed restoration of epicardial coronary flow has improved the conductance in the vessel of these patients, but some of the IFR values even decrease afterward, which is something difficult to explain, if not that there was some sort of hyperemia that was unmasked by doing balloon occlusion of the vessel. So is this true IFR or some hyperemic IFR? Next point on the agenda, hyperemia unmasks what is relevant to the interventional cardiologist. Hyperemic transtenotic pressure gradients, in other words FFR, specifically informs on the hemodynamic impact of the epicardial lesion on coronary flow. Basically tells us whether it's worth to implant a stent on a coronary artery segment that is affected by stenosis. Now, whether the patient might also have ischemia coming from microvascular dysfunction is of interest, for sure. It might justify some residual ischemia after treatment, but it's not something we can fix with our percutaneous treatment. FFR accurately predicts abnormal, non-invasive functional testing, and FFR-directed PCI is the only index that was ever demonstrated to revert abnormal results of non-invasive functional testing to normal. I invite you all to go back to this seminal paper from Pijls back in 1996, nicely demonstrating this concept. Last point on the agenda, prognostic importance of hyperemic assessments. I think we have now overwhelming evidence that is supporting an important prognostic role of abnormal FFR values. In other words, the lower the FFR values we obtain in our measurements, the higher the risk of cardiovascular events, both at lesion level on the left and at patient level on the right. In addition, we can significantly interfere with the risk of the patients. How? By implanting stents on those lesions with abnormal FFR. By doing that, the steep line that we see on the right side in this meta-analysis of Niels Johnson flattens down. Means really that we are treating what's relevant to the patient's prognosis. We are treating ischemia-inducing stenosis and the sort of ischemia-inducing stenosis derived by the epicardial atherosclerotic burden. We have also obtained data, long-term outcome data from the DEFER trial that taught us that it's safe to treat medically those patients with coronary stenosis with preserved fractional flow reserve instead of putting a stent. We have data from the FAME-1 trial up to 5 years that told us that actually that FFR-directed PCI is better than angiography-directed stenting. And finally, data from FAME-2 trials up to 5 years informing us that it's better to improve flow by implanting a stent, where it's necessary, of course, than treating patients with a relevant ischemia with medical therapy. We have also heard about the prognostic importance of hyperemic assessments performed after PCI. In other words, the functional gain that we can obtain by performing our revascularization. This is a recent paper published by Stéphane Fournier, where he has measured the functional gain as difference between post versus pre-PCI FFR value. And the delta between the two was correlated with the clinical outcome of this patient. So what he has demonstrated is that where the functional gain is the lowest, where there is not much to gain by implanting a stent, there is not much difference in the FFR that you induce with your stent, then the clinical outcome of these patients will not improve that much. So it means that perhaps those patients derive their adverse clinical outcome from somewhere else, from microvascular dysfunction perhaps. So in conclusion, only during hyperemic conditions, intracoronary pressure measurements can reliably inform on flow. Resting conditions are extremely difficult to obtain in the cath lab. Hyperemic CAD assessment provides information specific to the epicardial stenosis. And finally, invasive functional assessment under hyperemia is the only tool showing long-term prognostic value. I think we have undisputable data on this. And I thank you very much for your attention.
Thank you, Emmanuel. The paper is open for discussion. Are there questions or suggestions or notes from the audience?
Or criticism.
Or criticism, yes.
Objection, why not? I hear a voice in the background, or it's in the other room?
Yeah. Yes. please take the microphone and yeah.
My question is, thank you, very, very good and informative talk there, Emmanuel. Do you think we should be checking the FFR after PCI? We're obviously a little discouraged when we check and it's not 0.93 on the FFR or similar on the IFR. And what should we do? We're obviously working hard for secondary prevention, making sure the patient is on everything. Sometimes it's just, even if it's not small vessel diffuse disease, there's obviously endothelial dysfunction. So should we spend the extra 10 or 15 minutes to perform that assessment, would you say?
You've got, you pose a very important question, and I'm not sure I have a fully convincing answer. The point is that angiography is a limited tool. So if you decide, what invasive physiology is telling you, I would state it simple, is telling you, and you can 100% rely on that, is treat or not to treat. Once you decide to treat, my preference would be, if you don't trust angiography, on intravascular imaging. Why is that? Because then you can decide for how long should be the stent and how long should be the segments to be treated. Why am I speaking of limitation of angiography? I'm speaking about that because you can never be 100% sure that what you're doing is correct. What you can still do with invasive physiology is to perform a nice pullback, trying to analyze the pattern of the coronary atherosclerosis, diffuse disease if you don't see step up versus focal stenosis. This can be surely done. But I think the best way would be to have already a strategy in mind, decide upfront, okay, this is what I'm going to do for this patient, and decide also when you want to stop, because the risk can be that if you keep measuring physiology after stenting, you end up with a full metal jacket, and I'm not sure we are doing something good to the patient. Sometimes you can leave with a suboptimal post-PCI, suboptimal. Nobody can say what is suboptimal post-PCI in terms of FFR results. We know that the higher the better, this we know it for sure. How much this will impact the clinical outcome, as you said, it depends a lot on the secondary preventive measures. I agree, it's not a fully convincing answer, but I guess it's the best answer I can give.
Sorry, just one related question. So how long do you tend to run your adenosine infusion? So before or after? Do you run it for 4 minutes? If you haven't got a result of less than 0.8 or less than equal 0.8, or is 2 minutes sort of adequate with GTM?
That's a good question again. Thank you very much. This pertains about how much you trust your hyperemic response to intravenous adenosine. So in a way, the fact that patient is referring some discomfort is telling you that something is going on in the circulation of this patient, so it's a good feedback. Secondly, if you don't see a nice hyperemic response, a good trick could be to inject intracoronarily a bolus of contrast, for example, just to be sure that indeed this patient has achieved maximal hyperemia or some sort of hyperemia, and why not, you can even give IC adenosine on top of IV adenosine to be sure that you have reached more or less the plateau. Other than that, there might be additional trick to increase a little bit the dosage of adenosine. There are some colleagues giving up to 180, 210 microgram per kilogram per minute. That's another option. Or give regadenoson or Rapiscan, I don't know. We will talk about this.
But with adenosine, it also depends on the way of administration. If you use a central venous line, mostly you are fully hyperemic within 1, at the most 1.5 minutes. If you use a peripheral infusion, it can take somewhat longer. But there is not one rule for all. You have to look at the tracings and decide, am I hyperemic or not? Other questions? Yes, sir.
Can you explain a little bit about the absence of concordance that exists between in the 20% between the patients that you perform FFR and IFR? Why this happen?
Well, what you see mostly, the most common discordance is a negative IFR and a positive FFR. And that is quite common, especially in lesions more than 70%, with, in young persons, large proximal coronary arteries. And that is related to the nature of Pijls equation, which contains a linear component and a quadratic component. The linear component is the friction in the lesion, and the quadratic component is the separation. And especially in large proximal lesions in younger persons with a large perfusion territory, that quadratic component is important. And then you can quite often see up to 30% of the cases that at rest things seem to be normal, but at hyperemia there is a large gradient within the coronary artery. And this is the group of patients where IFR or other resting in the chest is false negative. And that's what I pointed to in my introduction. Those lesions are excluded from analysis in the defined flare and in the sweetheart study. So let's say the more moderate you make the patient population, the easier it becomes to prove non-inferiority of one lesion to the other. But also the advantage of using the technique becomes less compared to angiography. Well, I think we will continue with the next presentation by Professor Oldroyd from Glasgow, and he will discuss the different hyperemic drugs and FFR assessment.
Just to briefly mention the post-PCI FFR scenario, there are at least 3 randomized trials ongoing using physiological optimization to attempt to achieve different post-PCI FFR targets. So at some point in the next 2 or 3 years, in fact I see the fellow who's running one of them in the back of the room at the moment, so in the next 2 or 3 years we may have a definitive answer. So this is my second favourite slide in the field of invasive coronary physiology. Emmanuel's shown my favourite slide, which is the 1996 paper from Nico and colleagues. So this is a beautiful study where patients had repeated assessments of fractional flow reserve using intracoronary and intravenous adenosine, and also adenosine triphosphate, which produces almost identical results, intracoronary papaverine, and of course intracoronary contrast medium, which has recently had a little resurgence of interest in it. And you can see each of these lines represents multiple measurements in the same patient. The summary is that all of these agents produce similar levels of hyperemia, except for contrast here. You can see here 6 cc's of intracoronary contrast medium, which produces a degree of hyperemia, but it's not maximal. And I'm going to go through some of these agents in a little more detail over the next few minutes. So just to start with intracoronary contrast medium, everybody has this available in the cath lab during an angiogram. As I say, it produces submaximal rather than maximal hyperemia. We've studied this in the contrast trial published in JACC 3 years ago. And interestingly, just to again refer back to the discussion about resting indices, you can see here that if you look at the 2 resting indices of IFR and resting PDPA, and this ROC curve, their levels of agreement with FFR are identical, and we have that discordance of 20%, which was referred to by the previous question. But when you give contrast with hyperemia, you get much closer agreement with FFR here with an R value of 0.929, because of course you are inducing a degree of hyperemia, albeit that it's not maximal. Now we switch to the classic hyperemic agent of adenosine, or indeed you can substitute ATP for adenosine if you have it available. So exogenously administered adenosine causes profound microvascular dilatation. It's mediated by specific receptors on the resistance vessel myocytes. And importantly, the hyperemia is independent of metabolic demand. Now you can try doing supine bicycle ergometry in a cath lab with catheters up from the radial artery and wires down the coronaries, and some groups are doing that. But of course it's far simpler just to induce a maximal hyperemia pharmacologically. And the primary method of administration is intravenous infusion, usually 140 mg per kilo per minute, as was used in all of the randomized trials. You must give nitrate up front to prevent epicardial vasospasm. That's the standard dose, and as Nico said, classically it was given through a central vein, but modern large caliber cannulas placed in an antecubital fossa vein will give you flows that are very close to central access. And of course, if you're using adenosine for stress perfusion MRI imaging, then of course you would be using peripheral cannulas. The peak effect is relatively quick, 30 to 45 seconds, with the effect wearing off in approximately the same time frame. And one of the critical advantages of steady-state hyperemia induced by intravenous adenosine is that it allows you to do a hyperemic pullback curve. And this is an underutilized invasive physiological parameter, which is again attracting a lot of attention now, and also allows you to measure CFR and IMR, which potentially can inform on the status of the microcirculation. AV block is much less common with IV adenosine infusion than it is with IC adenosine, but it can provoke bronchoconstriction in patients with, particularly with asthma, or in the occasional COPD patient who's got profound reversible airways obstruction. And Nico will address this issue in more detail in his final talk. It is usually accompanied by an angina-like sensation, which can be associated with dyspnea. And that's important because it allows you to know that the adenosine is actually working. However, it does not indicate myocardial ischemia. It's usually well tolerated. You simply have to advise patients up front that they're likely to feel something. And of course, encourage patients to breathe normally through that sensation to avoid any Valsalva maneuver and an impact on systemic hemodynamics. In terms of safety, we have looked at the use of intravenous adenosine in patients with STEMI or very recent myocardial infarction. And this is almost 300 STEMI patients and 350 non-STEMI patients. Almost 90% of the patients did report symptoms during the adenosine infusion, but there were no serious adverse effects. And of course, all of the symptoms rapidly resolve after the infusion ceased. So that's a high-risk cohort, if you like, with half STEMI and half non-STEMI. Aortic stenosis is another situation where functional assessment of coronary disease is being increasingly used, particularly as part of the workup towards TAVI. This is an interesting paper looking at the use of IV adenosine in patients with severe aortic stenosis, elderly patients, in fact, with severe aortic stenosis. And in their hands, the infusion was very safe, very well tolerated. There were hemodynamic changes, as you would expect with maximal hyperemia, but no serious adverse events. So in both those high-risk situations of acute coronary syndrome and severe aortic stenosis, the use of intravenous adenosine infusion to induce maximal hyperemia is very, very safe. Now I want to talk briefly about high bolus dose intracoronary adenosine. And the reason we talk about high bolus dose is if you go back to the literature, when we started using IC adenosine, for instance, with Doppler wires in the coronaries, we were using 16 micrograms in the left and 12 micrograms in the right. You'll see that the doses that are being used now are much higher than this. So this is again being looked at in this paper from Bernard's group published in JACC. You can see on the left side the dose response for the left coronary artery, and on the right side the dose response for the right coronary artery, with the intracoronary adenosine doses along the bottom, starting at 4 micrograms, at working up towards 200, 300, or even 500 micrograms. You can see here this is the incidence of AV block. So you don't get an appreciable incidence of AV block until you get up to 200 micrograms on the left side. Of course, in the right coronary artery, where the artery to the AV node is a branch of the right, you see AV block at lower doses. However, the dose response curve is flat at 200 micrograms anyway in the left coronary artery, and the dose response curve is flat at 100 micrograms in the right coronary artery. So in general terms, we will start with 50, go up to 100. If we don't get any AV block, we go to 200. And this produces very stable and repeatable levels of maximal hyperemia, as you can see here. So this is 3 sequential administrations of high bolus dose intracoronary adenosine with FFR values of 0.53, 0.53, and 0.54. Very, very repeatable and also quick and, of course, inexpensive. Now, some practical points. Again, you have to use intracoronary nitrate to prevent epicardial spasm. We almost never use guide catheters with side holes anymore, but if you are still using side hole guide catheters, I would avoid that. You really need to make sure that the guide catheter has coaxial engagement. You need to make sure the analyzer is set to a beat-to-beat mean so that you don't miss the lowest value of the FFR. And when you inject through the guide catheter, when you inject the adenosine through the guide catheter, switch the three-way tap back as quickly as possible, again, so that you don't lose the aortic pressure tracing for more than 2 or 3 seconds. I'm grateful to my colleague, Dr. Collison, for providing this video of a high bolus dose intracoronary adenosine injection. So you can see here the FFR value. This is live, 0.76, 0.76, 3, 4, 5, 6, 7, 8 beats of stable maximal hyperemia with an FFR value of 0.76. I think you can trust that without any shadow of doubt, and then you can see the effects of the adenosine wearing off as we get back to baseline. Now going to shift to some other compounds. So in many parts of the world we're told that adenosine is difficult to get or expensive, but if you go to the Indian subcontinent, intracoronary nicorandil is widely available, and of course in Japan and Southeast Asia as well, where it's been used extensively for no reflow. We actually don't have this compound available as an intracoronary preparation in the UK, but there is good evidence to show that bolus dose intracoronary nicorandil also produces maximal hyperemia. So here's a nice paper published in CCI back in 2015. What we've got on the left panel here is high bolus dose IC adenosine versus IV adenosine, and of course this is an important finding, that you get basically the same levels of hyperemia with the IV and the IC. In the middle, you can see that's IC adenosine. In the middle here, we've got IC nicorandil, 2 milligrams, the same dose for all patients. You can buy 48 milligrams of IC nicorandil for a few dollars. That would be enough to do 24 FFR measurements. And you can see here that we've got FFR with IC nicorandil against FFR with either adenosine or ATP given intravenously. And the R-squared values here are very, very high. Well above 0.9. And I will not comment on the right-hand figure, as that will be addressed by the next speaker. Now, normally I don't talk about piperine when I'm speaking about drugs to give maximal hyperemia, but recently there's been, again, a little resurgence in interest in the use of IC piperine. I personally haven't used it for more than 20 years, but one of the interesting things about piperine is that it gets round any concerns that you may have, for instance, about patients not abstaining from caffeine. So if you've got somebody who's had 6 espressos in the morning and you're wondering if the caffeine's blocking the adenosine, then the mechanism of action of piperine is such that it's not antagonized by theophylline like caffeine, for instance. And that is a potentially useful mode of action of piperine. So you can see here 16 milligrams this time. This is not micrograms, so 16 milligrams in the left coronary artery and 12 milligrams in the right coronary artery, producing these very, very stable levels of maximal hyperemia. There is some prolongation of the QT interval, and previous studies have suggested non-sustained VT or torsad in less than 1% of patients because of this, but it's usually only in patients who've got bad left ventricular function and or severe coronary disease. And there's also an issue about using a contrast agent called hexabrix, which actually isn't widely used anymore, which precipitates with piperine if you inject them together. So these are 2 caveats to keep in mind, but if you have got intracoronary piperine, it works extremely well to induce maximal hyperemia. And of course, here's the interesting issue about the caffeine. So we often get asked about what are the effects of caffeine on FFR. And in this small study, the patients were being given intravenous adenosine to induce hyperemia. So 10 patients given 4 mg per kg of caffeine. That's quite a lot, by the way. That probably is about 6 espressos. And then FFR pre and post. You can see the caffeine levels went up promptly with this exogenous administration of intravenous caffeine. Maybe some of you would like intravenous caffeine in the mornings. But you can see the FFR values were completely unchanged in these 10 patients. A small study, but no effect that high doses of exogenous IV caffeine blocked the effects of adenosine in this study. There is conflicting evidence. Here you've got the comparison between piperine and IV adenosine. Remember, piperine will not be blocked by exogenous theophylline, but intravenous adenosine theoretically could be. There is pretty good agreement here, but when you look at the scatter plot, of course, there is variation, and the variation is predicted by how long the patient abstained from caffeine before the study. So blue squares, no abstention. You can see quite a lot of scatter on this bland Altman plot between the FFR with adenosine and piperine, right up to 48 hours of abstention, where actually there's almost no difference. So this study, which is a different design and looks at not exogenously administered caffeine, but caffeine that patients are ingesting in their normal diet, does suggest that in some patients there would be a difference between the FFR measured with piperine and intravenous adenosine, and perhaps represents a reason to have piperine available in the lab. We have a different way of dealing with this, which is that we ask all elective cases to abstain from caffeine for 24 hours prior to admission, and we send them a list of the foods and the drinks that they should abstain from. So drugs for hyperemia, in summary, as we've heard from Emmanuel, hyperemia is mandatory to assess the functional significance of a coronary stenosis. I don't think that's in any doubt. IV adenosine infusion is safe, it's repeatable, it's inexpensive, at least in our healthcare environment, and is generally well tolerated. High bolus dose IC adenosine is an even less expensive alternative, but it does preclude a hyperemic pullback or measurement of CFR and IMR. Finally, in some parts of the world, bolus dose IC nicorandil or piperine are available. They provide equivalent levels of hyperemia to adenosine, and they are also, as it happens, very inexpensive. Thank you very much.
Thank you, Chris, for this excellent overview. Take a seat here, and then the presentation is open for discussion. Can you take the microphone?
Do we give any allowance for intracoronary dose of adenosine if the patient has a left dominant circulation?
Well, you know, one of the nice things about IC adenosine is that you can essentially do a dose response in any individual patient. So, you know, I will go up with a dose, irrespective of whether it's a right or a dominant or a non-dominant left coronary artery. I would go up with the dose until I actually see some AV block. And then you know that you've maxed out on the dose response. Now, of course, I mean, the question can be answered in a slightly different way. The FFR value integrates the volume of viable perfused myocardium in that vessel. So, you know, if you get a surprising result in a dominant left coronary, then first of all, I would believe it. But of course, it may be that it's nothing to do with the dose of adenosine that you've given. That you may be dealing with somebody who's had a large anterior myocardial infarction, and actually the volume of, even though it's a left dominant coronary, the volume of viable perfused myocardium is less than you think.
Can you reach the microphone to the gentleman behind you? Question.
Thank you very much for a great presentation. And my question is about using adenosine D-phosphate. Is the same effect like ATP or not?
Yeah, it's pretty well identical. In fact, when we first started to use adenosine, both for SVT termination and indeed for inducing maximal hyperemia in the cath lab, we were actually buying ATP, and that's what we were using. And unless Nico and Emmanuel know anything to the contrary, my understanding is that they're virtually identical. So we were buying raw ATP from a chemicals company and making it up in the pharmacy.
There's a question there.
I have a question. Have you ever heard of variation in the quality of or concentration of the medication that you give IV or IC, depending on the fabricant?
What do you mean by the variation in the quality?
Variation in quality, that it doesn't work the same.
I assume that if it is bought from a company, it will be checked.
And a different company.
But if you make it yourself, I can imagine that there may be minor variations, but, well, at least in my country, some hospitals have the permission to prepare the drugs themselves, and I trust that when our pharmacy is preparing it, they make it in bags, 200 milligram and 100 milliliter, we use it for the IV, that it will be having the same quality. Of course, if you are in the unlucky situation that you have to mix things yourself in the lab, it is easy to make mistakes in calculations. For that reason, I recommend that if you use adenosine, that you try to make a standard protocol about the solutions you are using and to use it always in the same way. There is one last question from the back somewhere. Who was it?
Yes.
We saw a few patients developing atrial fibrillation during the injection of IV adenosine. This means something. This is a consideration for the choice of the weight of given in a patient with previous atrial fibrillation. Say something about the tendency of the patient to develop atrial fibrillation, what this means.
So, yeah, I mean, we've seen that, but very, very occasionally. Of course, adenosine, in addition to having effects on the AV node, does have some effects on atrial and indeed ventricular myocyte action potential characteristics. And, you know, there are reports, for instance, of adenosine-sensitive broad complex tachycardias and so on. So it wouldn't stop me using adenosine if someone was either in atrial fibrillation or had atrial fibrillation before. Normally, when I've seen AF developing shortly after an adenosine infusion, it's reverted to sinus rhythm very quickly. Occasionally, we've had to give patients flecainide back in the ward or some other intervention if necessary, but it's very, very, very rare. I mean, we're talking about something that I would say is less than 0.1%.
Okay, so if there are no further questions, I would like now to introduce our chairman and speaker at the same time, Nico Pijls, who's going to give us an overview and hands-on experience, his hands-on experience with regadenoson.
Thank you, Emmanuel. Ladies and gentlemen, while showing my conflicts of interest, I would like to note that there is a small video in my presentation which was made by Danielle Keulatz, Jo Zelis and Mohamed El Farizi. I'd like to acknowledge them for that. We have understood from the previous speakers that if we really like to know something about the strength of anything, we need to test it under stress conditions. When you are entering an airplane, you wouldn't feel very happy if the plane was only tested while standing on the ground. You like to have an airplane which has been tested in a wind tunnel under stress conditions. And similar is the case for the coronary arteries. The wind tunnel for the coronary system is hyperemia, stress. This is a patient, 59 years old, a lesion in a large proximal LAD, no symptoms at rest, but symptoms, typical symptoms at exercise. If you look at the ECG at rest, it is normal. If you look at the perfusion at rest, it is normal, no defect. And if you look at the intracoronary pressures at rest, they are normal. IFR is 0.97. But if you stress the patient, if you give hyperemia, he develops classical angina. The ECG is greatly abnormal. There is a large defect on the perfusion testing, and there is a large gradient with a significantly decreased FFR during hyperemia. And if you place a stent at that spot, you see that the stress ECG becomes normal again, that the perfusion defect disappears, and that the FFR also normalizes. So if we like to test the true strength of anything, we should do it under conditions of stress. We have also heard that many other physiologic indices like CFR and IMR require hyperemia. And only at hyperemia there is linearity between flow and pressure. And Emmanuel has focused to that resting conditions are very hard to obtain in the cath lab, and the resolution of a pullback recording at rest is 2 to 3 times lower, and the vulnerability to drift is 2 to 3 times higher under resting conditions. So it is clear that maximum coronary hyperemia is mandatory for correct decision making with respect to revascularization in the cath lab. And Keys has excellently shown that intravenous adenosine can be considered as a present standard to induce maximum coronary hyperemia. Other drugs are mostly compared to IV adenosine. It is reliable, safe, well investigated and reproducible, but in some centers, the non-trivial preparation, high price in some places, and need for central venous access might be a barrier. There is a new drug recently approved by the European Medical Agency for measuring FFR in the cath lab. That is regadenoson, a kind of a like drug to adenosine, a newer selective A2A receptor antagonist. And it can be administered as a single bolus. It is non-weight dependent, and it can be given in any peripheral vein. It's not completely new. There is extensive experience with regadenoson in the nuclear lab. There are a number of studies performed, some of them mentioned over here, and I will also show you a little bit about the experience in our hospital with the drug. I'd like to discuss shortly a paper by Lukien van Nuenen, a meticulously performed study in 100 consecutive patients where repeated measurements of both peripheral and central adenosine and regadenoson was performed. So there were 100 patients scheduled for FFR measurement, either diagnostic or interventional. PA was measured by the guiding, PD by a pressure wire. Patients had a central venous line for the adenosine infusion and for central venous regadenoson infusion, and they had a peripheral venous access for peripheral infusions. And these patients all got hyperemia determined by the IV adenosine, but also twice by the regadenoson, and they were randomized to receive it either central, peripheral, central, peripheral, and peripheral. This is the flowchart of that study. First an adenosine infusion, steady state hyperemia, waiting for being back on baseline. Then the first injection of regadenoson, waiting for 10 minutes, a second adenosine infusion, waiting again, and then the second regadenoson injection. These are the results of that study, and the left part of this slide was the most right part of one of the slides by Keys. You see on the horizontal axis the FFR determined by the adenosine, central intravenously, the gold standard, and on the vertical axis the FFR determined by regadenoson, and you see that there is a beautiful one-to-one correlation. Then the difference between central and peripheral, on the left hand the central administration, on the right hand side the peripheral, and you see that actually there is no difference between the both of them. And this is the reproducibility of regadenoson administered with an interval of 10 minutes, and also this reproducibility is similar to that of adenosine or other hyperemic drugs. This is the duration of action. In all patients, the steady state hyperemia lasted for at least 20 seconds. In 86% of them, it lasted for more than 30 seconds, and in 74% more than 1 minute. This means that in the majority of the patients you can use regadenoson for a hyperemic pool back recording. The disadvantage of what you see here is the variability in the hyperemic interval. It means that if you have multiple arteries, you cannot be sure that you still have hyperemia when you're doing the second artery. So that means that you have then to repeat the administration. This is the current use of Rapiscan in our hospital. In 2017 and 2018, we used it in about 40% of our patients. That corresponded to 1,250 patients. In the majority, there was one dose used, and in 218 of them, we used two doses. And these were mostly patients with 1 or 2 vessel disease and a radial approach. The side effects are similar to adenosine. In all patients, or almost all of them, you find chest pain, which is inherent to the mechanism of action, which is transient, and I should emphasize that, completely harmless. It was maybe slightly less with regadenoson than with IV adenosine. In a few percent, there were quickly transient AV conduction abnormalities. The hemodynamic response is similar to adenosine, about 10% decrease in blood pressure, 10% increase in heart rate. We didn't see any asthmatic complaints, And we did a repeated injection in 218 patients without any problem, with an interval of more than 10 minutes.
For FFR measurement in
This is the video I
equivocal
mentioned.
coronary artery stenosis. During coronary angiography, often a stenosis is encountered of which the clinical meaning and the hemodynamic significance is unclear, such as the 70% proximal LAD lesion in a 60-year-old gentleman. Hemodynamic evaluation by FFR is indicated. Rapiscan has been approved recently for FFR measurement for investigation of such lesions. A single bolus of 400 micrograms is suitable for all patients and can be prepared ad hoc and injected as a bolus in the antecubital vein. Onset of action occurs between 30 and 60 seconds after intravenous administration. In this LAD stenosis, the pressure gradient at rest is rather small, but soon after administration of Rapiscan, stable maximum hyperemia occurs and fractional flow reserve can be measured. As already mentioned, onset of hyperemia after Rapiscan injection occurs within 30 to 60 seconds and maximum hyperemia varies between 20 seconds and several minutes, generally allowing an hyperemic pullback recording if desired. In this case, FFR equals 0.65, indicating the necessity of stenting this lesion. Here you see the same recording at low speed, showing the elegancy of this recently approved hyperemic drug. As such, Rapiscan is a valuable addition to the armamentarium of the interventional cardiologists.
Then a few words. When would you recommend adenosine? When regadenoson? You have to decide that yourself, of course. I can just give you the practice in our hospital. If we have one vessel disease, only focal, no need for a pullback, we use IC adenosine or regadenoson. If we have more diffuse disease with a need for a pullback recording, we need to use regadenoson because IC adenosine is not suitable then. If there is moderately complex disease, we also use quite often regadenoson. If we have complex multivessel disease with the necessity of multiple pullbacks, and especially if we know beforehand that we are going to measure FFR, then we use central venous adenosine. And if we perform ad hoc FFR measurement, often in a diagnostic procedure with a radial approach, it is comfortable to use regadenoson because patients have a peripheral IV line and you can just inject it over there. So it is a good alternative for IC adenosine to avoid intracoronary injection and a good alternative for IV adenosine except in complex multivessel disease. What about its advantages and disadvantages? The big advantage is that one dose fits all, no complex calculations in the cath lab. You can give it peripherally. It has a very rapid action. It always acts within 30 to 60 seconds, and it is ideal in an ad hoc FFR measurement. The disadvantages are that it has only been approved for 2 administrations with an interval of more than 10 minutes, and in some patients, less than 10%, there is no pullback recording possible. So in summary, Rapiscan is a valuable addition to the armamentarium of the interventionalist to create maximum hyperemia, and it can be administered as a single one-dose-fits-all injection in a peripheral vein without noticeable side effects. It acts very rapidly and has a plateau, generally allowing a hyperemic pullback recording. Thank you for your attention.
Are there questions to Nico? Well, perhaps I have a question to you. Who has experience with this new hyperemic drug in the room? Please raise hands. Okay, so beyond Keith and colleagues working with Nico, nobody else? Okay. Questions to Nico, please. Just come up. Yeah. The microphone there.
Thank you for that presentation. Great alternative to adenosine. I've got one question just on that 10% of cases you said where no pullback was available. If you did decide to then use intravenous adenosine to repeat that, do you have to wait for that 10-minute period as well? You said, when you've got to repeat Rapiscan twice, you've got to wait for 10 minutes.
Yes.
So if I did Rapiscan and I couldn't do a pullback, and I then choose to do FFR with adenosine, do I have to wait for 10 minutes as well?
With adenosine, it is not necessary at all. Okay. You can continue adenosine infusion, in fact, for half an hour if you like.
Yeah.
The patient will mostly have chest pain,
but
again, that is completely innocent. And sometimes, if patients do not have too much chest pain, and the nurse forgets to switch off the adenosine, it runs for a long time. Yes. So adenosine is not a problem at all. But with Rapiscan, I do not know what would happen if you would continue it, but in our experience, we did it twice with an interval of 10 minutes. So we only know for sure that if we do it in that way, it is safe.
Okay.
So for the time being, I would not recommend to use it more often.
Sure. But if I was doing a hybrid sort of case where I've used regadenoson and I haven't got my answer and I needed to do pullbacks and I switched to FFR with adenosine, there's no known sort of time
of course,
interval.
that is theoretically possible, but it's not very practical. If you know beforehand that you have complex disease with the necessity of pullback recordings, I would say use IV adenosine. And if you do a procedure, especially by the radial artery, and you say, oh, I need to measure FFR, I see 1 or 2 lesions, or I see a vessel which is diffusely diseased, and it is sufficient to have 1 pullback, you can use a regadenoson. Yeah.
Thank you.
One of the most interesting things about what we've learned with regadenoson is this variability in the duration of hyperemia. Now, of course, the non-invasive imaging guys don't know anything about this because they don't know how much hyperemia is going on. And you really do have to wonder, in centres that are using regadenoson with SPECT, for instance, or clearly it's attractive in chest perfusion MRI because you don't need a second infusion pump, they won't know. If they wait 2 minutes before they inject the gadolinium or the radioisotope, how do they know that the patient is actually hyperemic at that point? It just makes me even more concerned about non-invasive ischemia testing. Nico, how about patients who've blatantly got asthma, where we haven't tried it yet, we haven't come across anybody. Have you used it?
Yes. Well, asthma and the contraindication for adenosine is, let's say, a little bit overemphasized. If you have true asthma, I would avoid adenosine. But in COPD, so to say, there is no reason not to give it. And often when people are starting to use adenosine, the patient, of course, gets this feeling of dyspnea, and people confuse it sometimes with asthma. And if you have more experience, you will notice it only very, very, very rarely. And in my life, I have used IV adenosine more than 15,000 times, and I have only noticed 1 true asthma attack due to it. With regadenoson, our experience is much more limited, maybe altogether 1,500 cases, but we have never seen an asthma attack in that. I should say, if a patient is known with really allergic asthma, then we do not use it. We use papaverine. Shall I go to the conclusions?
Yes. Okay.
So again, ladies and gentlemen, to conclude, I would like to give you some key learnings or take-home messages, whatever you like to call it. In the first place, I hope that you agree with me that functional assessment for decision-making in the cath lab improves patient outcome, and that although in low-risk populations hyperemia may be omitted, FFR with full hyperemia remains the gold standard, as it has shown to improve outcome both in stable angina and ACS, in many RCTs with a superiority design, also in complex patients, and that is reflected by the recent guidelines. We have a number of safe and reliable options to induce maximum hyperemia in the cath lab. Among these, regadenoson is a valuable addition. We can use it if we like it in a rather simple way. It can be administered as 1 dose for everybody in a peripheral vein without noticeable side effects, except the transient innocent chest pain inherent to the hyperemic action. The onset is quickly, within 30 to 60 seconds, and the plateau phase generally allows a reliable hyperemic pullback recording. And it can also be used in asthmatic patients and in those with COPD with some caution, as I mentioned. Thank you very much for your attention. Have a nice evening.